Hi everyone, this lesson is on the condition known as osteopetrosis, which is also known as marble bone disease. In this lesson, we're going to talk about what this condition is, why it occurs. We'll also discuss the signs and symptoms, how it's diagnosed, and how it's treated. So if we were to actually look at the word osteopetrosis, the prefix osteo refers to bone, the prefix petro refers to rock or stone. So you can think of the words Petra or the name Peter, they all refer to rock or stone. And the suffix osis refers to an abnormal condition. So it's an abnormal condition of bone becoming stone. So that's a way to think about it. More specifically though, it's a condition involving defective bone resorption leading to thick, dense, and fragile bones. And this defective bone resorption is caused by a failure of osteoclasts. And osteoclasts are the cells that clear bone. We'll discuss this in more detail when we discuss the pathophysiology in the next slide. Now, there are three clinical forms of osteopetrosis. One is known as infantile osteopetrosis. The second is intermediate osteopetrosis, and the third is adult onset osteopetrosis. Now, there are two types of adult onset osteopetrosis, type 1 and type 2. Now, infantile and intermediate forms are autosomal recessive, meaning that we need two copies of a mutated allele for this condition to occur, whereas the adult onset form is autosomal dominant, meaning that it only requires one defective copy of an allele for this condition to manifest itself. Now, osteopetrosis is a rare condition. The autosomal recessive forms, infantile and intermediate forms, are more rare. They occur in only 1 in 250,000 people worldwide. And the autosomal dominant forms are more common, although still rare. 5 in 100,000 have the autosomal dominant form, or the adult onset form. And the age of onset is variable. It depends on the form or the type of osteopetrosis that you have. If you have the infantile form, the age of onset is going to be less than 1 year of age. If you have the intermediate form, it's going to occur in the first decade of life. And the adult onset form can occur in adolescence or in early adulthood. And it's often going to be found incidentally. So it's going to be found on X-ray imaging, for instance, for some other reason. If there's X-ray imaging, they may look and see some abnormality of the bone, and that is the way that it's diagnosed later in life. We'll discuss this in more detail when we discuss the diagnosis of this condition later on in this lesson. Now let's discuss the pathophysiology of osteopetrosis. Before we talk about the pathophysiology, it's important to discuss how a normal bone is modeled and remodeled. So a bone is in a dynamic state of being built and being resorbed. So it needs to be built up and resorbed over and over again to maintain a healthy state. So it's going to be built up and resorbed by two different cell types. The first is osteoclasts. So the osteoclast cell type is the cells that clear bone. This can be remembered by the CL in osteoclasts. Osteoclasts CL, clear bone, CL and clear. This is a way to remember that osteoclasts clear bone. And what they do more specifically is that they can bind to bone with integrin receptors, form what is known as a sealing zone, and then acidify that sealing zone. They use proton pumps and chloride ion channels and some other enzymes in that sealing zone to acidify that area and dissolve bone in that area where they bound to the bone, and that dissolves the bone, releasing minerals and other components of the bony matrix. So this is how osteoclasts normally function. They function to resorb bone. And the other cell type that's important in this healthy dynamic state of a bone is an osteoblast. Osteoblast build bone. So you remember that osteoblasts build bone by the B in the word osteoblasts. Osteoblasts, B, they build bone. So that's a way to remember this. So they can come along and fill in the bony matrix. And osteoblasts and osteoclasts can interact with each other. So osteoblasts can interact with osteoclasts by expressing something called rank L or rank ligand, and rank L can then bind to rank receptors on osteoclasts to activate osteoclasts. So this is a way that these two cell types can interact. So osteoclasts are actually derived from monocytes and macrophages, whereas osteoblasts are derived from mesenchymal stem cells. So this is a normal way that osteoblasts and osteoclasts function. This is what should take place in a normal, healthy bone. However, in osteopetrosis, there is some issue with osteoclast functioning. there is osteoclast dysfunction for whatever reason. Now, there are multiple genetic mutations that cause issues with osteoclast functioning. There are at least 8 mutations that can lead to issues with osteoclast functioning or the ability of osteoclasts to resorb bone. So osteopetrosis is going to be a genetic condition. Some of these mutations include a mutation in an enzyme known as carbonic anhydrase 2. And carbonic anhydrase 2 is an enzyme that catalyzes the formation of carbonic acid from CO2 or carbon dioxide and H2O or water. So this enzyme, carbonic anhydrase, takes CO2 and H2O and then takes them and forms carbonic acid or H2CO3. And that acid is going to be used in that sealing zone to help resorb bone. So if there's a mutation in carbonic anhydrase 2, this can lead to osteopetrosis. And more specifically, this mutation in carbonic anhydrase 2 is going to lead to the intermediate form or the intermediate osteopetrosis. Now, some other mutations that can occur include a mutation in the OSTM1 gene. And the OSTM1 gene is the osteopetrosis-associated transmembrane protein 1 gene. So this can be something that's mutated and lead to an osteopetrosis condition. Other mutations can occur in genes such as TCIRG1 and CLCN7, which is chloride channel 7. This is actually going to be the second most common mutation in osteopetrosis, and it's going to be the mutation that occurs in type 2 adult onset osteopetrosis. So if there are any of these mutations and there are issues with osteoclast functioning, we're going to have increases in osteoblast functioning or increases in the building of bone from osteoblasts. And all of this is going to lead to increased density or thickness of bone. So we have increased thickening of bone, but these bones are not going to be healthy. They're going to be prone to fracturing. Some other important issues that can occur in osteopetrosis, especially in infantile osteopetrosis, include bone marrow infiltration. So if there is unchecked osteoblast functioning, so osteoblasts continue to build bone, but we don't have osteoclast clearing bone, what can happen is the bone that's being built by osteoblasts can start to encroach into the bone marrow of long bones, and this can start to impinge on the bone marrow in those bones. And bone marrow in those bones is used to produce blood cells. So this can lead to issues we'll discuss in the next upcoming slides. And then we can also see issues with cranial nerve impingement as well. So again, if there's too much building of bone and not enough resorption of bone, cranial nerve impingement can occur. And the reason is because cranial nerves run through the skull through little holes in the skull known as foramina. And if there's too much bony growth, the foramina, the diameter of the foramina can start to shrink, and this can impinge on cranial nerves, and this can lead to cranial neuropathies, which we'll discuss later on as well. And we can also see issues with neuropathy in other parts of the body, which we'll also discuss later on as well. So let's talk about the signs and symptoms of osteopetrosis. The first type we're going to discuss is the infantile type or infantile osteopetrosis. This is also known as malignant osteopetrosis. This is going to be the most severe form of this condition. So we're first going to see certain early findings in this condition. And again, this is often going to be diagnosed in the first year of life because the findings are going to be so significant. These include failure to thrive and growth retardation. So the newborn is not growing as they should. They're failing to thrive. These are all going to be important red flags that we start to see with patients. We can also see issues with nasal sinus issues as well. So the nasal cavity and the sinus cavities can start to enclose due to too much bony growth. This can lead to nasal stuffiness. This can lead to paranasal sinus malformation or issues with breathing through the nose or through the sinuses, and increases risk of nasal and sinus infections. We can also see issues with delayed dentition. So the eruption of teeth can be delayed in these patients. And some other issues include proptosis or bulging of the eyes. So there's so much bony growth, so the eyes start to bulge out. And we can also see issues with osteomyelitis of the jaw. So osteomyelitis is an infection of the bone of the jaw. And this is due to impaired vascular supply in the jaw bone itself. So because, again, too much bony growth can start to impinge on blood supply in the jaw. This can lead to infection in the jaw. So that's something else that can also occur in these patients as well. And we can also see issues with pancytopenia. So pancytopenia is going to occur in infantile osteopetrosis due to bone marrow infiltration. Again, the bone starts to grow in and impinge on the bone marrow. This is going to lead to issues with bone marrow functioning, and the bone marrow is responsible for making red blood cells, and this then can lead to issues with red blood cell production, leading to anemia or low red blood cell level. What will then happen in these patients, because they're anemic, is that they can have extramedullary hematopoiesis. So extramedullary means that it occurs outside of the bone marrow. So it's red blood cell formation outside of the bone marrow. It can happen in the liver and the spleen. We can see hepatosplenomegaly in these patients, or an enlarged liver and spleen in those patients. We can also see issues with signs and symptoms of anemia. These include fatigue, pallor, dyspnea or shortness of breath, presyncope or dizziness, and syncope or fainting. So these can all be something that can occur in these patients. We can also see issues with low levels of platelets or thrombocytes, so thrombocytopenia. We can then see signs and symptoms of thrombocytopenia, including petechiae. So petechiae are these little red dots. These are actually superficial bleeds under the skin. Purpura are little larger areas of superficial bleeds under the skin. And then bleeding can also be an issue. So prolonged bleeding, issues with stopping bleeding, this can be something we can see in thrombocytopenia. And then we can also see low levels of leukocytes or white blood cells. So we can see leukopenia. And this is going to increase the risk of infection in these patients. So leukopenia and anemia are going to be really significant for these patients with regards to morbidity and mortality. Because they're at an increased risk of infection and they have issues with anemia, they can be at an increased risk for mortality. We'll discuss here in a moment. These patients can also be at risk for neurological symptoms as well. These include cranial nerve impingement. Again, the foramina starts to narrow in the skull, leading to cranial neuropathies. And we can also see some nerve palsies as well in other parts of the body. Cranial neuropathies can lead to impingement on the optic nerve. So we need the optic nerve or cranial nerve 2 for sight. If we have an impingement on the optic nerve, we can have blindness. In other patients, they can have an impingement on the vestibulocochlear nerve, which can lead to deafness in those patients. So those are some of the manifestations of cranial neuropathies we can see in infantile osteopetrosis. Some other findings include increased risk of bone fractures, renal tubular acidosis. So renal tubular acidosis is something that we can see with intermediate osteopetrosis. Again, that's the type that is caused by carbonic anhydrase 2 mutations. So we can see renal tubular acidosis. Renal tubular acidosis is where the kidneys do not acidify the urine appropriately. So they're not going to acidify the urine. They leave acidic or acidified products in the blood. So the blood becomes more acidic, but the urine does not. This is renal tubular acidosis, more likely to occur in intermediate osteopetrosis. And then these infantile osteopetrosis patients are at an increased risk of mortality, again, due to anemia and leukopenia, especially that increased risk of infection. They're more likely to have increased risk of mortality in the first decade of life, especially if not treated. The next set of signs and symptoms we'll discuss is in the adult onset osteopetrosis. So adult onset osteopetrosis is also known as benign osteopetrosis. Again, we mentioned that there are two types. There's type 1 and type 2. Both types may be asymptomatic. Up to 50% of patients with adult onset osteopetrosis are asymptomatic. They don't have any symptoms at all. We'll first talk about type 1. Type 1 is a very mild clinical presentation. It's actually caused by a mutation in the gene LRP5. And some clinicians may not even consider this type 1 as osteopetrosis because this type does not actually have issues with osteoclast functioning. So although it's categorized as type 1 adult onset osteopetrosis, some clinicians do not consider it osteopetrosis because there's no osteoclast dysfunction in this type. Again, it's due to a mutation in LRP5. Again, very mild clinical presentation. There's no increased risk of fracture in this type, but there is still osteosclerosis. There's still a thickening of bone, especially in the cranial vault or the top of the dome of the skull. That's where we're going to see increased thickening of bone. We can also see some cranial neuropathies in this type as well, but again, it's going to be mild compared to other forms of osteopetrosis. And then type 2 adult onset osteopetrosis is going to have increased risk of fractures. In fact, 4 in 5 patients will have had fractures at some point in their life, and 40% will have repeated or recurrent fractures. These patients can also have early onset osteoarthritis, especially of the femur and the hip. They can have issues with anemia, so they can have issues with mild anemia, mild compared to infantile osteopetrosis, but they can have issues with anemia in some cases. And they can also have issues with cranial neuropathies as well, again, more mild than infantile forms. So they can have issues with hearing loss and facial palsies as well. And they can also have issues or have an increased risk of carpal tunnel syndrome. And patients with type 2 adult onset osteoporosis and other forms of osteopetrosis can have a shorter stature. They can be shorter on average. And they can also have issues with bone pain. That can be some common finding in these patients as well. Now, intermediate osteopetrosis is going to be in between infantile and adult onset osteopetrosis. It's not going to be as severe as infantile, but it's not going to be as mild as adult onset osteopetrosis. And it's going to be diagnosed in the first decade of life, as opposed to infantile, which is often diagnosed in the first year of life. So again, they can have issues with some of the findings in infantile osteopetrosis, but not as severe, but again, not as mild as adult onset osteopetrosis. Let's discuss how clinicians diagnose osteopetrosis. So again, imaging is going to be the key hallmark way that we can diagnose this condition. So oftentimes we can see what we would discuss or what we describe as stone or marble bone. And this is where we would see diffuse symmetric osteosclerosis. So thickening, dense bones, it's going to be diffuse, many different parts of the body, and it's going to be symmetric on both sides of the body. We can also see something that is described as bone in bone or endobones. These endobones are going to be found in the pelvis, so we can see them in imaging of a pelvis. These endobones are not going to be found in type 1 adult onset osteopetrosis. Again, we can also see increased bone density. And we can also see something called Rugger-Jersey sign. And Rugger-Jersey sign is something that we can see on the spine of patients. It's going to be due to prominent sub-end plate densities of vertebrae. So it leaves this alternating density and lucent pattern. And it can look like a rugger jersey. So this is something that we can see with adult type 2 osteopetrosis and not something that we can see with adult type 1. So again, rugger jersey sign, something we can see with type 2 adult onset osteopetrosis, but not type 1. And then we can also have transverse banding of the metaphysis, again, something we can see with type 2, but not type 1 as well. We can also find certain findings in the blood work that can help with diagnosis. These include increased creatine kinase BB, increased tartrate resistant acid phosphatase, and increased serum acid phosphatase. This is going to be elevated in adult type 2, not elevated in type 1. So with regards to infantile osteopetrosis, it's going to be diagnosed in the first year of life. We can often see pancytopenia. So if we were to do blood work looking at a CBC or complete blood count, we would see low red blood cell count, low thrombocytes or low platelet count, and low white blood cells. And then we would see some other findings on bone imaging as well. With regards to intermediate, that is going to be diagnosed in the first decade of life. And it's going to have some similarities to infantile, but not as severe. And then with regards to adult onset osteopetrosis, we can often look at some of these other signs to help determine the diagnosis and help distinguish between type 1 and type 2. And again, adult onset osteopetrosis is going to be diagnosed usually in adolescence and early adulthood. It's going to be diagnosed incidentally. And it's usually going to be diagnosed if a patient comes in for some x-ray. It could be due to a fracture. If they come in, they have a fracture, they get an x-ray done, they can see some of these findings that we've talked about before, or they can just have an x-ray for some other reason and they can see these findings, and that can be enough to make the diagnosis. Once a clinician has made the diagnosis, how do they treat osteopetrosis? So vitamin D supplementation can be used to treat this condition. Vitamin D supplementation, especially higher levels of vitamin D, can help stimulate osteoclast functioning. So this can be something that can be used as a treatment. So again, high levels of vitamin D. So vitamin D supplementation is one way to treat it. Treatment of anemia is going to be important, especially in infantile and intermediate forms of this condition. Interferon gamma 1b therapy has been shown to be effective as well. And then bone marrow transplant may be curative in some patients, especially in infantile forms and some intermediate forms. If the bone marrow is removed and new bone marrow is replaced, because the bone marrow is required for producing cells like osteoclast, having new bone marrow in may produce osteoclasts that do not have issues with functioning. So that is something to make note of as well. So bone marrow transplant may be curative in some patients. surgery is going to be important. We are likely going to need surgery because we need to surgically correct fractures. Again, many fractures can occur in these conditions, although complications are going to be common. So complications include non-union, delayed union, and osteomyelitis. Patients with osteopetrosis are at an increased risk of all of these complications when surgically correcting fractures. And because patients with osteopetrosis can be at an increased risk for having compression of the optic nerve leading to blindness, surgical decompression of the optic nerve is going to be a necessity for those patients to help retain vision for those patients. Please check out my lesson on Paget's disease of bone. If you haven't already, please like and subscribe for more lessons like this one. And as always, thanks so much for watching, and hope to see you next time.